1980s, several different disciplines got together in Rome to discuss these functional GI disorders, and they have had a couple of meetings since then. The last set of criteria came out in 2006 called the Rome 3 criteria, and then there's going to be another one coming out, I believe, in 2016. But this particular Rome 3 included 18 countries, including developing countries. So this is functional GI disorders really are everywhere. And if you want more information about functional GI disorders in Rome 3 criteria, you can go to their website. It's called romecriteria.org, and there is a wealth of information on there, and I have no power. Oh, it is? Okay, I didn't touch anything. Okay, so I just thought that you should be just aware of that because there's a lot of good information. There's also a definition that comes from the National Association of Pediatric Gastroenterology, Hepatology, and Nutrition, which is affectionately known as NASPGHAN. And they have guidelines that are on their website, and I have that on the resources at the end. These came out in 2006, and it really was guidelines established primarily for primary care physicians. They have nice algorithms, what to do with infants and children, you know, how to rule out organic versus non-organic constipation. So this was the definition that they came up with. But I've over the years discovered that, you know, the most important aspect of defining constipation is really the consistency of the stool. So as we'll talk about later, there's a lot of times that people are focused more on the frequency, and 9 times out of 10 it's the consistency that's most important. So obviously, it's very common. If you look at different studies, they'll say that 3 to 5% of all visits to general pediatrics are going to be for constipation or because of a perceived defecation disorder. And the reason I wrote perceived, this is probably the one time I might mention infants in this talk. You probably are aware there's a lot of people that will bring their babies in afraid that their baby is constipated because he or she is turning red in the face and screaming for 20 minutes before passing a soft bowel movement. That's called infant dyschezia. That's actually on the list of the Rome 3 criteria. It's a functional GI disorder. And that obviously is important to educate our families that that's not actually constipation. So that's why I wrote perceived. There are certainly in our experience, we see the vast majority of the kids presenting around the preschool years, but in general, there are sort of a handful of times that kids are more likely to develop constipation. A big time is when you're transitioning from breast or formula to cow's milk at 1 year. Another time, of course, is around potty training, and then again at school entry. So when you're working in primary care, those are really important things to factor into your anticipatory guidance. So if you can let families know that, you know, yes, as you're getting ready to make these changes, just be aware that this or this might happen, and maybe we can work on making sure the child is getting a good diet and that we're intervening as quickly as possible if the bowel movements become hard. So anticipatory guidance is really important. A couple of other general points that I want to make, and the reason I'm talking only about functional GI or functional constipation today is because only a small minority of children will actually have an organic cause for their constipation. So the vast majority are functional. And I'll talk to you about how I explain this to parents under the education piece. But really the most important reason why I'm talking about this today is because this is a significant concern for the families. They really, really worry about this. They think it's really serious. They come in thinking that there's something really terribly wrong with their child. So it causes a lot of worry. And then certainly there's a lot of lack of knowledge about how this whole thing comes about. And when you have a child who gets to the point where they become encopretic or they're soiling because of their constipation, that can put the child at great risk for abuse and punishment and things like that. I can't tell you how many families, when I explain to them how soiling occurs, I've had families literally sit there and cry because they have been punishing their child, thinking that the child was lazy or doing it on purpose, and they feel terrible about that. So that's another reason why this is an important topic. So in terms of what causes constipation, I'll talk a little bit later about pain retention cycle, which is a term that we use a lot when we're educating our families. But basically, these are just some common reasons for kids to become constipated really at any age. And even in any specialty that you might be in, if you have a child on a medication that might constipate them, that could set up a pain retention cycle that will go on. And I always tell families that children really are at unique risk for long-term constipation because they're kids. As adults, we know that sometimes things are not always easy, but kids, you can't tell them to just tough it out. They're not going to willingly go in and have a bowel movement if they think it's going to hurt. And then I think that certainly our lifestyles and our children's schedules are such that they're really too busy to take time to go to the bathroom. They're not given time in classrooms or the opportunity, or they don't want to go to the bathroom at school, or they're going right from school to, a sports practice. So there's not a lot of time for them to pay attention to their bowel habits. So I think a real key to success is recognizing the problem. Certainly we see a lot of kids, and in primary care you'll see this as well, that come in with chronic abdominal pain. And I would say the vast majority of kids that we see in our clinic have constipation as the cause of their chronic abdominal pain, particularly if it's generalized or periumbilical. So as one of our colleagues says, it is constipation until proven otherwise. So basically, the other thing I wanted to point out, and you guys probably know this, you'll get a lot of kids that'll come in with this complaint of chronic diarrhea. And I always ask, is your child making it to the bathroom, or are they having an accident? And is that what you're, terming diarrhea? And it's amazing how many times these kids actually are soiling and it's not truly diarrhea. The parents are looking at the consistency of the stool as being liquid and thinking that the child can't hold it. So just be alert for chronic diarrhea may not be as it seems. And then, of course, a lot of times, and it looks like we've got, okay, there. So oftentimes it's associated with urinary symptoms. Our urology colleagues can certainly attest to this. A lot of times they get sent patients that have new onset nocturnal enuresis or urge incontinence, a whole bunch of different things, or chronic UTI, and no classic history of constipation. And 9 times out of 10, they are discovering constipation and putting the kid on treatment and sometimes sending them to us. So it's really a common cause of urinary symptoms. So it's always important to determine if fecal impaction is present, and that can usually be accomplished by doing a good history, an abdominal exam, and that's pretty much it. So as I said before, the reason why this is important is because if we recognize it earlier, it's easier to treat it, and we can also prevent encopresis if we treat constipation early. Again, children often have incomplete bowel movements. This is where getting back to the consistency of the stool. I can't tell you how many times families come in and say, but my child is not constipated. This might be a kid who's coming in with chronic abdominal pain. Well, how often does he have a bowel movement? Oh, he goes every day. It's completely normal. Now, mind you, some of these older kids, I don't think there's any way the parent is going in with every bowel movement and looking at it, but the kid will describe something that's completely normal, and they are flabbergasted when you bring up the possibility that this could be constipation. But I talk to them about the most common form of constipation in kids is actually incomplete defecation. They poop every day, they're just not pooping enough. So in that instance, that can be one of the few instances where it's helpful to get an x-ray. If you've got a child who they swear up and down are not constipated and they're coming in with chronic abdominal pain, getting an x-ray can sometimes be really reinforcing to teach them about that. By and large, I would say that x-rays are not usually needed. If you have a child who comes in with, obviously a classic presentation, they're withholding, they're complaining of pain, there's an anal fissure, or they're soiling, you don't usually need to get an x-ray to confirm that diagnosis, and you can spare them from that. So when I'm talking to kids, we talk about poop all the time, and the kids at first are incredibly embarrassed, especially the older kids. But I'm like, look, this is what we do, and we make it fun. So if they really, really don't want to talk about all the nitty-gritty details of their bowel movements, I'll pull out a Bristol stool chart, which you can pull up on any computer just by Googling it in the room. And then they can point to the bowel movement, and we talk about the size. We talk about the consistency. What does it feel like? Does it hurt? Does it take a long time to go? Is there blood with it? So this is just kind of a guide. I don't use it a lot, but it's there if you need it. So the next point I want to make is don't be afraid to treat early. If you see a child who's coming in with stool withholding, hard bowel movements, infrequent bowel movements, anything like that, you're not going to do much harm by treating early and breaking the cycle as early as you can. So the first aspect of treatment, and the most important, I would argue, is education. So a lot of what we do in our clinics is explaining the process of digestion and how stools are formed and how all of this occurs, particularly when it comes to encopresis. They really need to understand the physiology behind that. I talk to them about what the word functional is. So if I see a child who comes in with chronic constipation, the parents are really just freaked out that there's something terribly wrong, but there's nothing in the history of the physical exam that worries me. I tell them that the most common reason for children to have constipation is because of something called functional constipation, and I explain what the term functional means. What I'll say is it means that there's no underlying disease process, there's no structural abnormality, it's just the way things are working in his body right now. And the biggest reason for that is the pain retention cycle. So if a child has a bowel movement that hurts, they're going to try to hold it. If they hold it, it gets drier and harder, and then it hurts again, and then they try to hold it again. And when you explain that cycle to them, they really get it. Many times parents will say, but he's trying, he's straining, he can't go. And they're worried that there's like a blockage and that the poop won't come out. And I explain to them that when the child looks like they're trying to go, they're actually trying not to go. So that's a really important distinction as well. Most children are not going to just hang out there and strain and try really hard to go. They're going to just try to avoid it and wait for the urge to pass. So I spent a lot of time talking about sort of normal digestion, how waste is processed, all of that kind of stuff. And we have, on my next slide, and hopefully I can get it to work, our national organization, NASBGAN, has a foundation that was able to partially fund an educational video specifically for families and children. It was created out of the Children's Hospital of Colorado by a nurse practitioner working in GI there. It is available on the NASBGAN educational website for families, and I've got the website address in here as well. You can go there. You can send your families there. I send my families there all the time. This is a brand new video, and it's the coolest thing because it kind of talks in their language about digestion and waste and how encopresis occurs, things like that. The video online is over 5 minutes long. So what I did is I edited it down so that you could just kind of get a glimpse of what is contained in it. The first part of it is about, what happens when you eat your food and it goes to your stomach and it goes through your small intestine. So I skipped over that. And then it talks about how when the waste enters the colon, water is pulled out and it moves down. So I just kind of skipped over a lot of that because I just wanted you to get an overall feeling of what this video can do. But I strongly recommend this to everyone. So let's see if we can get this to work. All right, there has to be a way to make this bigger.
The purpose of this video is to explain why soiling accidents occur and to help you understand what you can do to stop them from happening. Poo accidents can be embarrassing. Many children who have accidents can't tell when they're coming and they're not able to stop them from happening. However, it doesn't always have to be this way. When we eat food, it travels from the mouth, down the throat, and into the stomach. In the stomach, when the poo enters the large intestine, it is liquid. As it travels through the colon, water is absorbed back into the body and the poo becomes more solid. The rectum is like a balloon. The first time it's blown up, it returns back to its original shape and size. However, if it's repeatedly blown up, it eventually becomes big, flabby, and weak. This stretched out rectum becomes a large holding area for poo, setting up the process to repeat itself. And with an overstretched rectum, some children lose the urge to poop. By following these steps every day, a big and flabby rectum will return back to normal, but it can take up to a year for the rectum to regain its original size and tone. So by sitting on the toilet every day and having a poo, you will prevent the backup of poo into your colon. Your stools will stay soft and will be easy to pass. And best of all, there will be no accidents.
So obviously what I skipped over there was like everything. I just wanted you to get an idea of what is available out there. This is very simple terms. The kids find it fascinating and they get it, and it really helps the parents as well. So feel free to check that out. Let's see. Oh boy. No, now it's not going to let me go to the next one. There we go. Oh. Sorry about that. I don't see an icon on the left. Oh. Okay, I think that was the next one. Yes, okay. So part of what we do in the education after describing the process of how constipation occurs and particularly how encopresis occurs, I spend a lot of time talking about the myths. These families come in armed with information from the internet and from their friends that say that things like Miralax is dangerous and they're afraid that it's the same thing as antifreeze, and there's a lot of myths that need to be dispelled. So the first thing I talk to them about is the concept of osmotic laxatives, things that pull water into the colon. We talk about how Miralax is, safe. A really important element of this is explaining to them that Miralax doesn't cause soiling. And we're going to talk about this a little bit later. But a lot of kids come in that have had a history of encopresis. They've been put on Miralax, and it seems like their soiling gets worse. They seem to have diarrhea, and things are worse. So the families immediately think, oh my gosh, this Miralax is too much. It's too strong, and they stop it. And then the soiling gets worse or continues. And that's because any child who's soiling needs to be cleaned out first, and the Miralax will kind of make it look like they're soiling more when in fact that's not the case. So even in the handouts that I give them, and I verbally will tell them that Miralax does not cause soiling. If your child starts soiling or resumes soiling, it means that there's too much stool accumulated in the colon and we need to deal with that. So, and I also tell them right at the beginning that most cases of constipation, and especially encopresis, you're looking at, especially the really bad stool withholders, we're looking at many months of treatment. With encopresis, it's 6 to 12 months minimum. And I've been following some kids for years. They're doing okay, but you can't pull back. Every time we try to pull back, things get, a little dicey again. So it's important that we treat well. So I did want to say a word about high fiber diets and fluids and things like that. Obviously, that's very important for our children to be getting good, healthy diets with plenty of fiber. I use the AAP guidelines of 5 grams plus the age of the child as a rough guideline to how much fiber they need. You can go overboard with fiber. Kids that have really hard bowel movements or withhold, if you go overboard with fiber, that can actually make the bowel movements worse. But it's important to have that as a basis. But once a child becomes really constipated on a chronic basis, and certainly if they have encopresis, a high fiber diet alone is not going to touch this. We need to be able to really treat it with good stool softeners and some other things we'll talk about in order for the constipation to be resolved. So I see lots of kids who come to me who are older, sometimes 11, 12 years old and older, who have had encopresis for all of that time, and they've been told that, use a high fiber diet, or, don't worry, he's going to outgrow it. They don't outgrow it. If a child is soiling, you need to help them. So, And again, I really want to point out that if you see constipation, treat it early so they don't develop encopresis, because encopresis is extremely distressing to our families and these kids. It really affects their self-esteem greatly. And relapses are common, so I make sure that the families understand this in my education piece. And again, children with encopresis must be cleaned out. That's a takeaway message. So in terms of what we use to treat, I have in one of the last slides, sort of like a reference slide, information about how we do some cleanouts with oral laxatives, primarily using the Miralax, the PEG 3350. There are some people that will use mag citrate. A lot of times we'll use the Miralax with the bisacodyl. Sometimes we'll use Senna, which is like X-Lax. And we do, I swear to you, try very hard not to admit them to the hospital for cleanouts. So those that end up in the hospital for cleanouts, it's really because the family just cannot manage it. Or they have legitimately tried to do the clean out at home and maybe the child vomits or they won't cooperate or you're just not getting any stool production. So those kids that end up coming into the hospital are really our worst cases. So the vast majority of them are being cleaned out at home over 1 or 2 days. So we used to do, in the old days, we used to do more disinfection rectally. That's not done as much. I do have some older kids that actually don't mind getting enemas. And if that's the case, sometimes I will say that's a good starting place. We can kind of get the ball rolling with that. But I would say that this is not done very much anymore for obvious reasons. I mean, kids already have a traumatic association with things on their bottom, and if we're going in and trying to do rectal disinfection, they're not real happy about it. There are a lot of EDs that are still doing different kinds of enemas and things like that in the ED, but in general we try to avoid the soap suds, tap water, and I think molasses is still being used too. Okay. So in terms of maintenance, you guys all know about Miralax. It really has, I think, been studied adequately that I feel that I can tell my families this is safe. It's not absorbed, there's no side effects, it doesn't cramp, no gassiness, and again, it does not cause soiling. So in terms of dosages, there's a couple of different guidelines for dosages, but in general, I would say that most of the kids that I see that are over the age of 3, I'm usually giving them 17 grams a day. I have some teenagers who need more than that, who need a couple of capfuls a day, and there are even younger kids that need that. You sort of titrate it depending on the consistency of the stool. If you have a child who is a big-time withholder, some of these, kids that are around potty training ages, sometimes they need huge doses of Miralax before they stop withholding. I mean, they can really be amazing. And the goal with those kids that really, really, are withholding is to get their poops to the point where they're really, really soft and that they can't withhold them anymore. Those are primarily the kids that are not yet potty trained, where you can really watch that. We'll sometimes use stimulant laxatives along with the stool softener. I find that this is fairly helpful in little girls that have dysfunctional elimination. There are a bunch of girls that have the urge incontinence and uresis, and who also have the encopresis, and a lot of them are around like 4, 5, 6 years old, and they are just checked out. They don't feel anything. They just don't know when they need to go. You get them on scheduled toilet times, and they just never seem to really produce enough. So sometimes I'll put those kids on X-Lax at night, and then a really good toilet time in the morning, and then keep them going with their Miralax. And that the X-Lax seems to give them a little bit more of an urge and that they can't ignore, and it helps them to be more productive. So you'll sometimes see those things used together. So basically, this is just sort of a rough guideline of the kinds of dosages that we use, but it's usually at least several months, and then again, in the case of encopresis, it's a minimum of 6 months, usually way more than that we're using the maintenance Miralax for. If we're using something like X-Lax, it's usually only for, maybe a couple months at the most, or maybe intermittently. So obviously a really important part of our education and treatment is toilet learning. If you remember with encopresis, when they have the stretched out rectum, their sensation is decreased. It takes a much larger volume of stool for them to register that they actually need to have a bowel movement. So I make sure that the families really understand that, and that's why we have the kids sit on the toilet at scheduled times. Because if we wait for that child to have an urge, we're missing opportunities. They're not going to have an urge as often as they should. So I always make sure that they sit on the toilet after every meal, particularly after breakfast. And I'll have a lot of families who are like, we're too busy, it's too crazy in the morning, or he's eating breakfast at school or whatever, and I'll just say, look, wake up 5 minutes earlier. If your child eats breakfast at school, that's fine, but maybe we could still have him sit on the toilet before you leave, because most children are more comfortable having a bowel movement at home. And if you keep practicing this, the child will be able to have a bowel movement in the morning, and then they don't have to worry about it all day, and that would be really cool. And the kids kind of like that idea too. So practicing. I'll get into a little bit about some relaxation maneuvers that I will use, because there are some kids that really resist sitting on the toilet. And it can really be any age, but they're like, no way am I going to do this, and you can't make me, and I don't need to go. And there's a lot of power struggles that go on. So I talk directly to the child about why this is important, and we sometimes will come up with a strategy like, okay, let's see if we can make the toilet time a little bit more fun. And I'll have them create their own bag of toys or box of toys that they are only allowed to use when they have their potty time. And I'll include, things like obviously books or music, or if there's a game they like to play. Just, it has to be their special thing. Their siblings can't use it. It's only for them. And sometimes that will help to motivate them a little bit more. And I usually will tell families to use reward for cooperation with the toilet times rather than rewarding the child for having a bowel movement. I just kind of feel like, we shouldn't have to reward them for pooping, but we should reward them for doing what they're supposed to do, their potty times. And they seem to really understand that. So I have had some families who have found that their children are a little bit more receptive to negative reinforcement. We don't usually start there, but there's this whole kind of carrot and stick approach, and there are some kids that, if you tell them, I'm going to give you a point or a prize when you cooperate, or if you go for a week without soiling your underwear, that doesn't mean much to them. But if they find out that they can't play video games, if they had a soiling accident that day, that registers with a lot of kids. So really, a lot of it will really depend on that particular child. It's absolutely essential to get the school and the daycare involved. A lot of these kids are spending a tremendous amount of time away from home. That's not to say that we should dump all of this on the school, and there have been instances where I think families are expecting that the school is going to do more than they are. At the very least, the teachers need to know that the child needs to have free access to the bathroom. If they need to go, they shouldn't be asked to hold it, so there's that. Some kids, I will set it up so that after lunch every day, they go to the nurse's office for a 5-minute toilet break, where they have privacy and they feel like, those bathrooms at schools are busy and they don't have enough time and they're embarrassing and all of that. So I'll set that up if I need to. A lot of the kids that I see, though, are fine with a after breakfast sitting, and then as soon as they get home from school, they have a snack, and then before they're allowed to do anything, they have to sit on the toilet for 5 to 10 minutes. And then if need be, they can do another one after supper if they haven't pooped yet that day. But I've had a couple of instances where families were a little bit chaotic. One particular kid comes to mind from last week, where I said to the mom, okay, so he's eating breakfast and lunch at school, and then he's, before school, after school, daycare. Who's helping him? He's only like 5 or 6 years old. Well, the lunch lady is helping him, and I'm like, the lunch lady? How is that? The poor lunch lady. So I picked up the phone and called the nurse, and I said, this is what I was told, and she said, that's impossible. There's no way the lunch lady is helping this kid go to the bathroom. So we came up with an idea of what we could do. So anyway, another thing that I do want to make sure that I bring up is that you have to get rid of the pull-ups. I am amazed at how many kids come in wearing pull-ups and they're 5 or 6 years old, and that's because they're soiling so much and underwear is expensive and they're throwing it out. But I assure the families that if we do the clean out, that's going to stop. But if you put the child right back in pull-ups, you're sending a message to that child that he is not capable of staying clean. So it's, and I think on a subconscious level, they feel like, oh, I don't have to worry about this. They don't have enough skin in the game when they're wearing a pull-up. So that's a really, really important aspect of this. There are some schools I've dealt with who have insisted that the child wear pull-ups there, and I've had to pick up the phone and talk to them and let them know this is, how we treat encopresis and what the protocol is. If it's a child over the age of potty training, it's unacceptable for them to be in pull-ups. And interestingly, most of our school-aged children who have encopresis don't soil at school. They are able to hold it together all day. Somewhere in the back of their mind, they just know that this would not be cool. And the minute they get on the bus to go home, that's when they have their accident. So the vast majority of kids, that's the case. But there are exceptions to that, certainly. So in terms of follow-up, you have to treat for long enough. That's another thing that we see a lot, where I'll see families that'll come in and they'll be like, yeah, well, he's constipated. We put him on Miralax. Things got better. And then we started to wean it and we stopped it. And then it came back. And they've done that over and over and over again. I'm like, well, why are you doing that? Why don't you just leave him on it? And, they worry. Again, they worry about, what is this Miralax? I don't want my child to be dependent on it. It's a medication, or somebody told me that we should get him off it as soon as possible. So that is a huge piece of what we do in education, is explaining that it's safe and it's better to treat really, really well for a short period of time than to be on again, off again, on again, off again, which can go on for years. I mean, let's just deal with this and put it behind us, and then we can worry about getting them off the Miralax. So that's important. And then I always talk directly to the child. I mean, I've got some kids that are soiling all the time, and I'll just, sit them down and say, how does this make you feel? And a lot of times they shrug their shoulders. Some kids legitimately don't. They seem like they don't care, but you can usually get them to, if I can't get them to talk, I'll say, well, is it a thumbs up, a thumbs down, or maybe in the middle? How do you feel about this? And they almost always do this, they feel bad about this. This really affects their self-esteem. They worry. They worry about going to visit friends. They feel like they don't have control over their own bodies, and that's really tough. And then if you have somebody who maybe where the families are legitimately getting frustrated with it, tired of cleaning up underwear, tired of constantly telling the kid to use the bathroom and worrying that the child is being lazy. That really, really has a huge impact on these kids. So that's really one of the biggest reasons why I'm so passionate about this subject, because I think these kids feel really, really bad, and we have an opportunity to prevent it from getting that bad. So the goal is always a daily soft bowel movement in the toilet for those that are already potty trained without soiling. Any continued soiling means that we are not where we need to be. So if I clean them out and they go for a period of time where they don't soil and then they start soiling again, you got to clean them out again. And then sometimes I'll up their daily treatment so that we don't have to keep going back and doing that. So there's a lot of adjustments that need to be done. So, certainly I do a lot of phone work with them, and I try to bring them back fairly often to make sure that everybody is on board. And so I have a chance to talk directly to the child rather than just getting all the information from the parents, because the child's perspective on this is obviously the most important. And obviously we congratulate success. When these kids come in and they have gone for a long period of time without having soiling, they are so happy. They're very, very proud. I've had kids that literally would not look me in the eye, wouldn't talk to me, and then on subsequent visits, it was just a completely different visit. And I'm talking some kids that were like 13 and 14 years old. So it's a big deal. So what I wanted to also mention was some what we call alternative treatments. And a lot of this, I'm going to talk separately about self-hypnosis, but I wanted you to be aware of biofeedback. A lot of people get that mixed up with self-hypnosis. And it's similar, except that in biofeedback you have machines, basically, that will give biofeedback to the patient in terms of muscle relaxation or, temperature or things like that. It's much more of a sort of a physical kind of a situation. So we don't currently have pediatric biofeedback for encopresis officially. There are places that we can refer to, and there are some, I would say most of the time we're more interested in getting the kids with the dysfunctional elimination into biofeedback, particularly the little girls who are wetting and soiling all the time no matter what you do, and they just really do not seem to know what's going on down there. So, but it's tough. The literature on biofeedback is only so-so in terms of success. I think it's a little bit better with enuresis. I don't quote me on that, but for encopresis, there aren't great results, but I think that I think it has potential. A lot of people who do biofeedback are just trained. I have colleagues around the country who do biofeedback, and they're just trained by whoever makes the machine. They haven't, done like a long biofeedback, process and course. So I think it has potential. I wanted to mention these other things here because these are like probiotics, flaxseed, aloe, chiropractors, things like that. Your families are going to come in with a list a mile long with things that they've read about on the internet or things that their friends have told them. I've seen little babies brought to chiropractors for constipation. So there's, any review of literature that's been done on these particular alternative treatments have not shown that there's really any good trials to make an assessment as to whether these work or not, including probiotics. I mean, the type of trials that have been done, they're too small, they're not randomized, all of that, and that's true for a lot of the dietary stuff. There was a review that was done in 2011 in the Netherlands, I think it was, that looked at all these different sort of alternative things, and the only thing they could find was one fairly reasonable study that showed that fiber supplementation was better than placebo for treating constipation, but all the other stuff didn't seem to make a difference. But again, the studies were small and they weren't well designed. And I think it's important for us to know what they're doing. I always ask specifically, what have you tried? Have you done something, have you picked up something over the counter, herbals, things like that, and they'll tell you. And I just make sure that they understand that, these aren't studied. In the case of probiotics, I'm not opposed to using them. I don't, if the child is otherwise healthy, it's not going to be harmful. But they're really expensive. So, I'm not going to just tell people to go out and buy something that may or may not work when I know that there are other things that for sure will work. I mentioned flaxseed. There's been a couple of at least one study fairly recently, and I don't have the reference with me, that looked at ground flaxseed, using that for irritable bowel syndrome and constipation. And it looks like it has some favorable results, but again, it's not a big study. And then I've had a couple of patients who have come in drinking huge volumes of aloe vera juice. I don't know where they got this idea, but I don't think it's safe. I mean, from what I've been able to read about it, it can cause, electrolyte disturbances and a cathartic colon and all of that. I don't know. I don't recommend it. That's one of the ones that I'll say, I don't think that's safe. But flaxseed, that's not going to hurt anybody. Probiotics, probably not. But again, those things are expensive, so I don't just tell them, go for it and whatever. So just a word about self-hypnosis. So certainly I'm lucky enough to be here where I've worked with Dan Cohen and his group and whatnot with the learning pediatric self-hypnosis. I've taken 3 courses now, and it is incredible. I've done it specifically. Well, initially I did it for children with chronic abdominal pain, functional abdominal pain, and it's been really valuable. But I find that it's also really helpful with constipation and encopresis. And what I can do in the course of a typical visit is just helping the child with some relaxation. A lot of these kids go to the bathroom, they think they're going, they think they're pushing, and they're not. They're actually tightening, and they don't realize that. So part of what I do is just some simple deep breathing things, and I'll just teach that to them in the clinic where we work on just slow deep breathing and how when they sit on the toilet they have to rest their feet on something so that they feel secure, and we talk about doing slow deep breathing. Now, if this is a child who's younger who can't grasp that concept, I'll have them use bubbles, blow bubbles when they're sitting on the toilet, or blow a pinwheel. And they love that. They think that's really cool. That goes into their little special toy bag that they're only allowed to use when they have their toilet time. So that they really enjoy that a lot. But I think in encopresis, when I do some of these techniques with them, it's really primarily because they've lost that sense of mastery. And that's really something that I think self-hypnosis can give back to children, is realizing that you do have some control over your body and there are things that you can do to make it better. So that's really the focus. I don't do as much formal hypnosis as I would like, because within the context of our visits, there's a lot to cover. But I always hope that in subsequent visits I can work on children, work with children who need it, who might not be responding to our regular treatment. So the last thing that I want to say is that I've got a whole list of references here, and obviously I could do like 40 pages of references, but the top two are the most important. So NASPGHAN, our national organization, has the constipation practice guidelines that were developed specifically for primary care doctors, and the gikids.org is where you're going to find that video, and lots of other patient education materials that I refer patients to all the time. They have excellent information on eosinophilic esophagitis and celiac disease and a whole host of other things. Good links for functional GI disorders. And then the last slide that I had that you should be able to access when you leave here today is just our disinfection protocol using the Miralax and the Bisacodyl. So we have time, lots of time for questions. Anybody have any questions? Yes.
In the emergency department, we see a lot of patients on Miralax, I think, like you said, for a few days and then stop it. So I think that a lot of practices in the community are using Miralax and Pullups. When should we refer patients to the GI?
Well, you know, theoretically speaking, referring to GI, I mean, I think most primary care doctors certainly can handle this, but a lot of this can be very time intensive, and within a busy primary care practice it can be tough. So if you see somebody in the ER who's been to their primary care, they've done X, Y, and Z, and they keep bouncing back, I think it's perfectly appropriate to send them to us, because we might be able to, you know, put a little bit more time into the education piece of it and getting them to understand. And interestingly, there's a lot of primary care doctors who are uncomfortable using Miralax for long periods of time, and they are the ones that are telling their families, oh, you know, as soon as we get to that point, then just start tapering it off. So, yeah, I think really any time. Yeah. Anyone else? Yes. Well, best candidate for self-hypnosis. Okay, really anybody. The first thing that we have to do is we have to explain what self-hypnosis is. So the first thing I do is I explain it to the parents and the child, and then I see if they're interested. So the main point that I want to make sure they understand is that self-hypnosis is self-hypnosis. All hypnosis is self-hypnosis. You can't hypnotize someone, and no one can have control over you. And I explain the process of what it is. I liken it to, you know, if you're reading a good book or playing a video game or watching a movie, how you get absorbed into it and you know, kind of are not you're not noticing things around you. So I explain that that's what it is, and if a child seems interested, you know, and the parents are like, yeah, sure, whatever. I mean, then it's. But some people are really like, no way, I'm not interested at all. If I have a child who's really who's got a lot of behavioral problems and who might be seeing a counselor or something, I don't go there, you know. But I will sometimes call their therapist or counselor and say, have you considered this? I'm seeing this patient for encopresis. Would you consider adding some self-hypnosis if you're trained in that? And I refer a lot of kids out, particularly kids that have also comorbid things like anxiety. I don't get into a lot of that. I'll send them to Dan Cohen's practice in Minnetonka and a couple of other places around. We have great resources here in the Twin Cities. A lot of people are well versed in it. Yeah. Yes? Well, actually, body posture, yes. That video, what I didn't show you in that video is, and I don't know if this came from Japan because I haven't read that study, but in this video they talked about how important it is to sit up straight on the toilet. And it used to always be that we would tell people to lean over. So there seems to be some bit of literature that's saying that being more upright seems to be favorable. And that's what that video really teaches them about posture on the toilet. So who knows? So. Anyone else? All right, well, thank you.